Ramucirumab is a monoclonal antibody, an antiangiogenic agent administered IV every 3 weeks that is FDA approved in the US in combination with docetaxel for previously treated patients. This is based on the REVEL phase 3 trial that was published a few years ago and demonstrated a significant improvement in multiple efficacy endpoints, but most notably overall survival in combination with docetaxel, and ramucirumab improved that even compared to docetaxel alone, which on its own has a survival benefit compared to supportive care. This has been taken up by some physicians, but not uniformly. But I think we are likely to see greater use of that in the future as we see a compression of chemo and immunotherapy into the first-line setting, often given concurrently, which has left us with fewer options for what has active utility in these patients who have already received chemo and immunotherapy. Importantly, when we look at who was on the REVEL trial and who's eligible for ramucirumab, this was for all histologies, unlike bevacizumab. This did allow patients with squamous as well as non-squamous non-small cell lung cancer. And the REVEL trial actually demonstrated that the benefit seen with that combination was even seen in the subset of patients who had received prior bevacizumab. So there were not safety signals that precluded patients based on histology or other factors from receiving the docetaxel ramucirumab combination safely. Even the patients who had received prior bevacizumab could benefit, and so it certainly is an option for patients. I use it in my own clinic, and I have seen good tolerability and efficacy with it. I am more inclined to use it now as I have patients who have a good performance status being delivered into the second-line setting after progressing, and now being good fit candidates for a combination in second line. And it's important to bear in mind that we are sometimes having patients who have received several lines of treatment, including those who have received a targeted therapy for a driver mutation. They may have gotten 1 or 2 lines of treatment for a driver mutation and chemo and then immunotherapy. But I would say that as long as patients have a performance status and bone marrow function that's suitable for treatment with docetaxel, you can add ramucirumab to that, and it really adds very little in the way of toxicity risk, but with that you get to confer a greater overall survival benefit. So I would be inclined to use it second line, but also be aware that it is studied in third line and very feasible for patients as long as they haven't received prior docetaxel and have the performance status and bone marrow function. I've used the combination of docetaxel and ramucirumab in many of my patients in the clinic, increasingly in the last several months to years. And the biggest toxicity issue I run into is hematologic. It's a greater tendency to need growth factor support, having patients who develop neutropenia, occasionally with fevers, most often without. And just by being very vigilant about monitoring their counts mid-cycle and being aggressive about initiating growth factor support when needed, that's really been about all that's been necessary. The nice thing about using the combination is that it hasn't really led to a change in practice. I've just needed to ensure that patients' counts are followed carefully, and that when you need to introduce growth factor support, you do that.